Hi, everyone. Thank you all for joining us. We will get started in just 1 minute. Dr. Thornton-Evans, whenever you're ready.
Thank you, Cassie. Hello, everyone, and thank you for joining us today to the CDC Dental Public Health Residency Lecture Series. Next slide, please. This lecture series is designed to help current and future dental public health residents gain a better understanding of the 10 dental public health competencies and of current topics in the field. These webinars are for current dental public health residents, prospective residents, and anyone interested in the field of dental public health. Each lecture in this series will occur approximately once per quarter and will feature experts in dental public health to provide a deeper dive into their experience and each competency. Each webinar will be announced via email, and the date will be posted to our website a few weeks in advance. Please send us an email at dphresidency@cdc.gov if you are interested in being notified in advance. This presentation and all presentations in this series will be recorded and posted on our Dental Public Health Residency Lecture Series page. Please feel free to type your questions into the chat box during the presentation, but hold all verbal questions until the question and answer period. Next slide. Our first presenter will be Dr. Thomas Gift, who received a BA in economics from the University of Colorado at Denver and a PhD in economics from the University of Illinois. He is the chief of the Health Services Research and Evaluation Branch in the Division of STD Prevention at the Centers for Disease Control and Prevention. He has been at CDC since 1997, and his work at CDC focuses on assessing the STD prevention infrastructure and public health and on the cost effectiveness of STD interventions. He also has conducted classes on prevention effectiveness and economic evaluation for EIS officers and other CDC staff, as well as serving as a guest lecturer for students at Emory University and Georgia Tech. And he has his thesis was on and dissertation committees for master's and doctorate level students at Georgia Tech and Georgia State University and Georgia Tech. And just to clarify, he's been on thesis and dissertation committees for both of those institutions. Our second speaker will be Dr. Susan Griffin, who received her PhD in economics from Emory University and began working with the Division of Oral Health at CDC in 1997. Her research has focused on documenting the burden of oral disease and the effectiveness and cost effectiveness of interventions to prevent dental disease. Her past recognitions include the National Center for Chronic Disease Prevention and Health Promotion's Director's Health Equity Award in 2017, the American Public Health Dentistry Public Health Service Award in 2012, and 5 nominations by the National Center for Chronic Disease Prevention and Health Promotion for the CDC Shepherd Award. Dr. Griffin has also received recognition for Student Merit Awards for Outstanding Achievement in Dental Public Health, being a finalist for the IADR Moretta Award in 2007, and winning the Social Behavioral Sciences and Health Services Research section of the IADR Student Abstract Competition in 2002. It is now my pleasure to hand it over to Dr. Thomas Gift and Susan Griffin.
Thank you very much. Give me 1 second to bring this up. It's great to be here today. Okay. So we're going to be talking about economic evaluation and applications to dental public health. Most of what we're going to be talking about today in terms of cost effectiveness and other types of economic evaluations are going to be focused at the top of this pyramid. This is a graphic from an article that was published by Tom Frieden, a former CDC director, about 10 years ago. And he noted that the layers at the bottom of the pyramid, socioeconomic factors and changing the context to make individuals' default decisions healthy, those require little individual effort and they have great population impact. That being said, much medical research and certainly economic research has focused on the top of the pyramid, and that's where we will spend most of our time today with examples. Prior to conducting an economic study, you have to answer some questions. The first one is to determine what it is you want to answer. What are you studying? What do you want to look at? What is the study perspective? We'll talk more about perspective in just a moment. Define the intervention and outcomes. For the particular question you want to answer, what types of interventions are relevant and what types of outcomes matter? 4, what are the relevant time frame and analytic horizon? We'll talk about both of those terms in just a moment. And then last, what type of an economic study is needed to address the question that you want to answer? Is it a cost analysis, cost effectiveness, cost benefit, or something else? So study perspectives. When economists and people who do economic analyses of healthcare talk about perspective, they're just talking about a given payer typically. And for a given payer, you include all relevant costs and averted costs over a standard time horizon. So an example that's frequently used in economic analyses is a program perspective. That's one health department, one agency, one school district. When you're looking at the costs that are relevant for those entities, you don't include direct medical costs that are paid by others. And cost sharing can impact this perspective. If you have, for example, Medicaid, Susan will be talking about Medicaid a little bit later, the cost is shared between state and federal. If you're doing a state perspective analysis, the amount of money that is paid for by CMS is not necessarily relevant to your study. From the healthcare sector perspective, you want to consider all providers and consumers of healthcare. So this is not necessarily just one insurer or one consumer of healthcare, but it's across the spectrum. You want to include all direct medical costs that are incurred within the time frame and analytic horizons that are relevant for your study, and patient copays matter here as well. The broadest perspective is societal, and that includes the entire economy. And here you include all costs associated with the condition and intervention, and things like patient costs start to matter for this perspective. If you have an intervention that requires the public or patients to make multiple visits to healthcare providers, for example, the time costs are going to be relevant from the societal perspective, but they're not relevant from the more limited ones. The panel on cost effectiveness in health and medicine, there have been a couple of them. They recommend using the healthcare sector and societal perspectives as the benchmarks for the analysis, but then note that the societal perspective is relatively rarely used. The most recent update of the panel looked at 1,163 studies, and they found that only a little less than a third of them use the societal perspective. Now, all of this being said, more limited perspectives are useful because they can identify barriers to implementation. If you have a perspective that shows that, say, from the perspective of a school district, something is relatively expensive, even if it is cost effective from a societal perspective, there may be some barriers to getting that intervention off the ground. For time frame and analytic horizon, the time frame is essentially the time frame that you're studying, and you want it to be long enough to capture cycles. And if you have some seasonality in patient visits or in morbidity, you would want to have a cycle that's long enough to capture the seasonality. If you have an intervention that starts, and so there's a slow startup state, and then it reaches a steady state, you want to incorporate both the startup and the steady state so that you're not measuring just one part of the intervention time frame that is different from others. The analytic horizon is how long you capture relevant health outcomes, and it should be long enough to capture the outcomes that matter for the perspective that you're using. And these outcomes can be good or bad. And the perspective does matter for both of these. Oftentimes in my field, STD prevention, some of the diseases that we focus on treating have outcomes that only are incurred with a great time delay. And an individual insurer that's looking at patients churning through every couple of years may not be interested in a 20-year analytic horizon. Then we also need to talk about discounting. This is the time value. Money available for spending today is worth more than the same amount next year. If I offered each of you $1,000 today or $1,000 a year from now, most of you would rather have the $1,000 today. I'd have to offer you more to persuade you to wait. A 3% discount rate is typical. So the $1,000 that I'm offering you today, I'd have to offer you maybe $1,030 in a year to make you indifferent between the two. And then similarly, if you can get $1,000 a year from now, I don't need to give you as much today to make you as happy as that $1,000 will a year from now. This is one of the reasons why for lotto jackpots, if you get a $100 million prize, that you walk away with about 50 or 60 million before taxes. They're taking a future stream of income and they're discounting it to the amount that they're going to give you now. So discounting applies to outcomes as well. A dental implant needed today, if you consider that to be a bad outcome versus one needed a year from now, well, the one that you would get a year from now is not as bad. If you're going to have something bad happen to you, you would rather put it off as long as possible. Then there's inflation. This is something different. We're all familiar with it, even though inflation has been relatively stable for the last 20 years or so in the United States. And this measures the change in prices or decreases in the purchasing power of money. So with inflation, if you want to buy some marshmallows with $1 today, you can get more today than you can get a year from now if prices go up a little bit. And so to adjust for inflation, we want to convert all prices to same-year dollars. This is relevant oftentimes because we'll be pulling data from studies that have happened over time, and something that uses, say, 1997 year dollars needs to be adjusted upwards. The money back then would have bought more than the same amount of money today. The discount rate, on the other hand, measures time preference. So this is which you would rather have. The value of eating a marshmallow today is greater than eating one next year. So again, if I want to make you indifferent between the two, I've got to give you more marshmallows a year from now in order to persuade you to wait. And so good outcomes, you have to add. Bad outcomes, it's not as bad to have it happen in the future. For economic analyses, there are cost analyses, cost effectiveness, and cost benefit. These are the broad domains that most economic studies fall into. A cost analysis is pretty simple. It just measures the cost of the intervention or illness. A cost effectiveness analysis takes the cost and it combines it with outcomes, and it expresses the cost of the intervention per unit of outcome. And this is useful for comparing interventions that achieve the same outcome. It's very good for that. And it's the most commonly used method in most fields of healthcare to look at economic evaluations of interventions, alternative ways of achieving the same end. Then there's cost-benefit analysis. Economists like this, and they think it's analytically most attractive because you convert your costs and benefits to dollars. A benefit-cost ratio over 1 means the intervention is beneficial. So let's talk about cost analysis first. When we talk about cost, we're talking about opportunity cost. It's not the same as the amount of money that changes hands, even though it's denominated in dollars. So the opportunity cost is the value of the best foregone alternative use of the resource. An example is a do-it-yourself oil change. If you want to have someone come to your office and change your oil in the parking lot, you can usually get this done for about $70 to $90, sometimes less, sometimes more. Or if you are a practicing dentist and you want to take an hour off, not see patients, and go out into the parking lot and change the oil yourself, it might seem attractive because then you'd only be paying for the oil and the filter. Say the materials are about $30. But the opportunity cost of foregoing that hour seeing patients, you're probably going to be losing about $88. That's what the Bureau of Labor Statistics says is the average salary for dentists. Some make more, some make less. But you see, once you add in the opportunity cost of the lost hour of work plus the $30 for materials, even though you pay less out of your checking account, the commercial on-site oil change ends up being better. Here's another way to look at opportunity costs. We have two brands of blueberry preserves. On the left is the Gift brand, and on the right is Smucker's that you can buy in any grocery store. So if you have blueberries, you can can your own preserves. The price for the Smucker's is about $2.62, and I figure that I've got about 83 cents worth of cash into that pint jar of blueberry preserves that I just showed you. I figure the jar is going to last about 10 sessions, so that's the apportioned cost, and then there's a jar lid and sugar that goes along with it. So the dollar cost of my preserves is 58% lower than the commercial preserves. Sounds like a bargain, but not really. When you add in the time cost, I figure that I have about 10 minutes of my life involved in the Smucker's blueberry preserves, because that's just an apportioned share of the shopping trip when I bought them. But I've got about 47 minutes in the pint of the gift brand. Mostly that is picking and processing. It takes time to pick the berries, and then you've got to heat them, mash them, put them in the canner and everything. So the cost difference ends up being $1.79, and the time difference is 37 minutes. Basically, what all this means is, unless my leisure time is worth less than $2.90 an hour, the blueberry preserves I'm making cost more. My leisure time is worth more than $2.90 an hour, but I'm still making blueberry preserves, so you may be wondering why you're listening to me. I can't take my own advice. So here's another example, and it's something to keep in mind for analyses of healthcare interventions. Here's a gallon of milk, $5.47. That's pretty pricey. It's organic. It's pretty good. And on the right, we have a box of powdered milk. It's more expensive, but when you consider how much milk you can make with that 4 pounds of powder, it's actually 42% less costly. But most of you, if you had a choice between the two and money wasn't involved, you wouldn't necessarily choose the powdered milk. You'd think that it's an inferior product. And so that's something to keep in mind with analyses of healthcare interventions. We're not necessarily going for the lowest cost. It's a combination of cost and outcome, and we want to get to the optimum. I'm going to turn it over to Susan now, who's going to go through a couple of dental examples.
Thank you, Tom. Good afternoon. Let's start by examining how the items included in a school-based sealant program would vary by the perspective done. And keep in mind, the key is the perspective internalizing the cost. So for example, from the program perspective, the school-based sealant program perspective, the cost that the program is going to pay are those that are associated with getting to the school, placing the sealants, and their administrative costs. Now, if we move up to the healthcare system perspective, they're also going to internalize the cost savings that are attributable to the averted restoration costs from the sealants. So you would include, in addition to that cost for the school-based sealant program, the additional cost of averted caries. Then from the societal perspective, we want to include all costs. And so from the societal perspective, we would want to include the value of volunteer labor and donated goods. Okay, next slide, please. Okay, I'm going to go over the, excuse me, so my computer just froze. Okay, so this next slide looks at the systematic review of the cost for school sealant programs. And this review is conducted for the Community Preventive Services Task Force. And here on, I'll just call it the task force. The task force looks at community interventions and conducts systematic reviews to evaluate their effectiveness and their cost effectiveness. And then these recommendations are in a document called the Community Guide to Preventive Services. So the school-based sealant program cost categories that were included in the task force review were labor, equipment, supplies, travel, and other costs. And if you look at that last column, the cost to seal a child, we see that there is wide variation in costs. That costs range from like $35 to $163 per student. But again, if we look at labor costs, again, we see wide variation in costs. But if we look at labor relative to total cost, we see that labor always accounts for the lion's share of total costs. If I look at labor as a percentage of total costs, it ranges from about 65% to 92% across these studies. So what does this imply, or what does it indicate for school-based sealant programs? That strategies that reduce costs per sealant unit, for example, using cheaper labor or reducing labor time per student could have a large impact on school sealant program costs. Next slide, please. Let's next look at the review of community water fluoridation. And again, we see wide variation in cost per person, ranging from 11 cents to $24 per person. But let's look at it now, just for systems that serve more than 20,000 people a year. And here, there's still variation, but we see that the costs are always less than $1 per person. So for community water fluoridation, we see that there are high costs for equipment. And the larger the public water system population is, the smaller the per person capital cost is going to be. So that's for community water fluoridation, you get higher returns if you invest in larger cities. Okay, next slide. So we're going to move from cost of the intervention to the cost of illness. And in dentistry, there are not many costs. They're looking at what are the total cost of caries in the US or the total cost of periodontal disease in the US. In fact, if you look at the global burden of disease, which tries to document the cost, they actually use total dental expenditures in the US. So when we're talking about cost of illness, again, perspective matters. I'm going to look at this slide on the costs that should be included in the cost of illness, and let's look at it from a health payer perspective. So from the health payer perspective, we know that we would include the cost for testing, diagnostic, for treating current caries, and for future treatment costs related with this, related to the sequelae of caries. We know that these are going to be paid out by the healthcare sector. Now, if we look at the cost for asymptomatic untreated disease, these would not be included because they're not going to be paid for by the health sector. When we get to prevention, it's a little bit more sketchy. Remember, the key is, is this going to be paid for if we avert the disease? Will this cost be reduced? And so, if we have an intervention such as fluoride varnish, and it's recommended that it be provided twice a year, regardless of whether or not the child has had caries, then that cost is not going to be impacted if we prevent caries. So for prevention, if the prevention would go down, if we, because we've treated the caries and perceived as being lower risk, then we might want to consider including some of these costs, but typically we would not include the cost of prevention. Let's go down to the next cost. Next slide. So there have been several studies documenting the cost of illness for treating caries in an operating room. And I'm going to review one study by Brune that is probably one of the most comprehensive studies, and that it looked at 6 states. Brune presented findings for 2010 and 2011. I'm just going to present the findings for 2010. We look at these studies, we find that the median cost per hospitalization to Medicaid is about $2,500 per case. So, if you have some level of, if I have sufficient prevalence, then this would suggest that among young children, OR costs could account for a disproportionate share of Medicaid dental costs. For example, we looked at treatment costs for young children in Louisiana. And so among Medicaid eligible children less than 5 years old, operating costs, accounted for over 25% of all their Medicaid treatment costs, and about 2% of kids were hospitalized. Okay, let's go to the next slide. Okay, so we're going to next examine net cost. And net cost is just the cost of the intervention minus the averted cost of illness. Now, note that net cost is the numerator of the cost effectiveness ratio. So I'm going to briefly describe the findings of 2 analyses of Medicaid claims data that looked at net cost. And the first is by Weintraub et al. And this was an analysis of the net cost to Medicaid from providing dental sealants. And this study was conducted in the early 2000s before all Medicaid agencies were reimbursing for sealants. So the authors used a two-part regression model, and they first estimated the probability that the child would have a caries-related expense. And then among those children with a caries-related expense, they estimated the average cost of for children in the sealed group. And the study found that averted treatment costs were greater than the cost of sealing children. That is, they were cost saving when the risk was high among children. For children at high caries risk, risk was defined as having 2 or more previous procedures that related to caries. Okay, let's move on to slide 21. The second study by Blackburn looked at the impact of a child visiting a dentist before age 2. So they compared cost among children who visited before age 2 to those who had not visited prior to age 2. And they had a somewhat, so net cost, first of all, would be the difference between the two groups. And we see that the net cost it was surprising because the cost for the children that had the visit prior to age 2 was almost double that of children who did not have a dental visit prior to age 2. Okay, so next slide. And this is due to both these studies were conducted using claims data. And when you use claims data, I mean, it's a very rich source of information for studies, but there are certain concerns when you look at claims data. And the first is selection bias. And selection bias is when the same factors that influence whether or not a child is assigned to the treatment group, i.e. whether they receive treatment, can also influence outcomes. For example, in the Blackburn study, it could have been that children who visited the dentist prior to age 2 had severe treatment needs, so thus they were at higher risk, so obviously they would have higher costs. Another issue is that provider preferences may vary by whether they provide prevention. So for example, if providers who provide sealants are more willing to wait and see if the caries progresses, then there's a higher chance that among those dentists that the caries could remineralize and a restoration would not be required. Now keep in mind, in both of the studies I reviewed, both try to control for these biases. Weintraub used an indicator variable for providers, and that would control for their difference in treatment preference. And Blackburn used propensity scores to try to control for differences in risk between children that visited the dentist early and those that did not. So let's next discuss cost effectiveness analysis. And a cost effectiveness analysis is the most commonly used form of analysis in healthcare. And let me start with a couple of caveats. A cost-effective intervention does not have to be cost-saving. Now, recall we said a cost-saving intervention was when the intervention's costs were less than the cost of averted disease. So for example, if it costs $20 to place a sealant and we save $50 in restoration costs, then we save $30 as cost savings. Now, does this mean that sealants are always, placing sealant is always going to be more cost effective than any other intervention? And the answer is no. And let me just give you one example. Suppose intervention A costs $10 to prevent a case of oral cancer, whereas intervention B saves $30 per case of caries. Are we going to say that the intervention to prevent oral cancer is less cost effective? And the answer is no. And the reason is that we're comparing different outcomes. So the community, next slide, the Community Preventive Services Task Force looked at the cost effectiveness of school-based sealant programs. And I'm just presenting the findings for the studies that used actual data for resources. So I'm not including the studies that did simulations or used net cost. And so there are two studies. The first was SHARE, and SHARE found that school-based sealant programs saved about $186 per child sealed. Now notice if the net cost is negative, then we typically stop there. It's hard to interpret a cost effectiveness analysis where the numerator is negative. The next study was by Werner, and they found that school-based sealant programs cost about $2 to avert one cavity. Taking these studies and the findings from simulations and the findings from net cost analyses, the task force found that school-based sealant programs would be cost saving when they targeted children at elevated risk for cavities. Let's go to slide 26, and let's look at the Community Preventive Services Task Force review of water fluoridation. And here we see that all studies included in that review found that water fluoridation was cost saving. And so we stop here, don't report a cost effectiveness ratio. And we see that the cost ranged from about $5 to $92 in savings per person. All right, so let me hand it back to Tom.
Okay, so when we want to look at interventions that achieve different outcomes, as Susan alluded to earlier, we need to come up with some way, if we want to do a cost effectiveness analysis, of harmonizing the different outcomes. And something that is commonly used is a health adjusted life year. Quality adjusted life years you'll see in the literature a lot. This is recommended by the panel on cost effectiveness that I mentioned earlier. And we're talking about quality of life. So perfect health, you have one quality adjusted life year, and death you have 0, and everything else is between 0 and 1. The example there, I won't take time to go through it in detail, but you just take the reduction from perfect health that a condition imposes upon you. This is ectopic pregnancy. It's measured in days, so I divided the result by 365 to get the quality adjusted life years lost per case of ectopic pregnancy on average. Then you may also see disability adjusted life years, DALYs. This is used especially in studies of international health and a lot in oral health. No disability here, we're talking about not having the DALY, which is good, that's 0, and then death would be full disability, and that's a 1. There are some methodological differences between those and qualities, but essentially you can think of them as the inverse of each other. I want to talk briefly about a study that was done. It's been updated twice, looking at A and B rated services recommended by the U.S. Preventive Services Task Force and vaccines recommended by Advisory Committee on Immunization Practices, ACIP. These are the services that were recommended for 0 copay and first dollar coverage by the Affordable Care Act. The way that these researchers analyze these wildly different interventions that accomplish different outcomes is they rendered everything in terms of qualities, and they used 2 different metrics. First is cost per quality. How much does it cost to achieve one quality adjusted life year over the alternative of not having the intervention? And then the clinically preventable burden, and that is just simply if you deliver the intervention at optimal levels to the percent of the population that is recommended for the service, how much morbidity are you averting? They ranked these in terms of best to worst, and then just divided the ranking into quintiles and assigned numbers to the quintiles. So 5 is good, 1 is at the bottom, the lowest performing quintile, and then they added the 2 quintiles together. So this ranking provides some guidance for prioritizing service delivery. It's necessarily broad, and it's not going to be applicable to all settings. It assumes clinical delivery, and there are a whole host of circumstances under which the cost to deliver the intervention will be different, or the adherence to the intervention and the health gains realized are going to be different. When you're doing something at a very high level, you can't get into minutia like this. That being said, it does provide useful information. Cross-cutting analyses are very important for decision makers at high levels. If you're a purchaser with Aetna or United Health Group or Kaiser, and you need to determine which preventive interventions to prioritize for the people who have insurance with your firm, then you need to be able to do something along these lines. And then the societal perspective, which is what was used for this analysis, may not match individual providers' perspectives. Here's the table of the rankings. It's too small. You probably can't read it very well. But here's the top cut out. The clinically preventable burden is off at the right, and the cost effectiveness, again, those are quintiles, so high numbers are good. And right at the top in terms of both preventable burden and cost effectiveness, the childhood immunization series, then some tobacco interventions, and so on down the line. And then they looked at about 45, I think, or 50. And next, let's talk about cost-benefit analysis briefly. As I mentioned, this expresses everything in terms of dollars, and it's analytically appealing for that reason. You put everything in a common metric. And then the benefit-cost ratio over 1 means the program delivers more benefits than costs. So this ratio can be used to select optimal interventions across different health conditions. If you want to look at the value of putting in a bicycle path to reduce obesity and improve cardiovascular fitness and prevent heart disease potentially, versus something like childhood vaccinations, this enables you to do that. But then you have to ask, how do you value non-monetary outcomes? One common way that this is done is contingent valuation. You try to determine how much people are willing to pay to avoid or achieve a given health outcome. So if avoiding a cancer death in year 2025 is worth something to you, you try to find out how much society values avoiding that outcome, and that gives you an idea of how many resources it makes sense to use to prevent that outcome. So here's an example. We can go through it very quickly. There are very few of these in the healthcare literature, actually, despite the analytic appeal. This is a supervised injection facility for people who inject drugs. This study was done in Vancouver, Canada. The benefits of a supervised facility are a lower death rate for potentially fatal overdoses because people go to the facility and they're injecting their medical staff on site who can intervene if needed. Potentially fewer HIV transmissions from injections because you can get new needles at the facility. Hepatitis C too, but they didn't look at that. The costs are for facility operation, and then there are costs with deaths and HIV transmissions, and you avert deaths and HIV transmissions, so it ends up being a negative $7.56 million cost. And then you end up with a benefit cost ratio of about 2.5 to 5, which suggests that these facilities do deliver a benefit. However, there are some obvious additional factors that inhibit introducing these facilities. They're starting to come into the U.S. in a limited degree, but so far they're not very common. And I'll next turn it over to Susan again for discussion of economic evaluation of policy.
Okay, so I'm on slide 35. So I'm going to describe one analysis of a policy to affect oral health, and then Tom will describe another policy. So I'm going to describe a study by Decker that was conducted in 2000. And this study examined if increasing Medicaid fees had an impact on dental utilization. And so the study used data from the National Health Interview Survey on whether the child had a dental visit in the last 6 months, and the child's dental insurance status, where they were classified as either having private dental insurance or being insured by Medicaid. And the NHIS data was combined with state Medicaid reimbursement rates for dental prophylaxis. And they looked at the prophy fee thinking that that would serve as a proxy for the generosity of overall Medicaid dental benefits. Decker examined changes in Medicaid fees and changes in dental utilization for two time periods, 2000, 2001, and 2008, 2009. Decker hypothesized that changes in Medicaid fees would have an impact on Medicaid enrolled children's utilization but minimal effect on children that were privately insured. And Decker tested this hypothesis using a logistic regression model that controlled for covariates, including sociodemographic characteristics, state effects, and time effects. So let's go to slide 36. So Decker found that increasing Medicaid fees did indeed increase dental utilization among Medicaid eligible children, but not among privately insured children. And she found that increasing from $20 to $30, the pro fee, it would increase utilization by 4 percentage points. And for states where the pro fee was greater than 30 or greater than equal to $30, there's no statistical difference in utilization by privately and Medicaid insured children. So more broadly, if we were to increase dental reimbursements by 33%, we could possibly remove the disparity in dental utilization by insurance status. Okay, Tom?
Okay, I'll give you one last example of a cost-effectiveness analysis. There are a lot of different ways that these things can be done. This is a study that we did a couple of years ago that used regression analysis to analyze the impact of federal STD prevention funding on reported chlamydia and gonorrhea rates. The Division of STD Prevention at CDC has an annual budget of about $150 million, much of which is pushed out to states and some directly funded cities for STD prevention activity, disease intervention specialists, surveillance systems, and the like. And you can look at the funds that are put in and the changes in reported STD rates to see if there's an impact. Chlamydia and gonorrhea are up quite a bit in recent years, and we did a regression analysis looking at the STD rate as the dependent variable on the left side of the equation, and then on the right side, one of the independent or predictor variables was STD prevention funding. And we found that a 1% increase in annual federal prevention funding might be associated with a little bit of a decrease in chlamydia that wasn't really statistically significant, more of a decrease in gonorrhea that did show some significance at p less than 0.05. Another study that has been done estimated that the net cost of federal STD funding for the 42-year period 1971 to 2003 was a negative $3.7 billion. When you include the direct medical costs of treating gonorrhea versus the reduction in 32 million cases of gonorrhea and the federal STD prevention funding over that time period. So that suggests that the budget is actually cost-saving to the American taxpaying public. Susan now can take it and do some summary and conclusions.
So let's look at what we've reviewed. So first of all, cost-effectiveness analysis is the most commonly used economic tool in healthcare. Why? It uses natural outcomes that are easy to obtain and easy to understand. So for example, in dental public health, we frequently use cavities or averted cavities. Getting information on averted cavities attributable to different interventions is quite easy, and it's easy to understand. When I say it costs $10 to avert one cavity, that's quite understandable to most people in dentistry. Using natural outcomes, however, does limit the usefulness of cost-effectiveness comparisons across different health outcomes. So, for example, which offers more value to prevent paying $10 to prevent a cavity or paying $1,000 to prevent a case of asthma? So we can address this somewhat by using metrics such as quality-adjusted life years, QALYs, or disability-adjusted life years, DALYs, which have a common metric, and they look at the loss in utility or the loss in quality of life attributable to having these various conditions. Now, in dentistry, quality-adjusted life year estimates for attributable to caries or to periodontal disease or to other oral conditions They're not readily available. Very few studies have looked at them, and some of the studies that have, there's been wide variation. Next slide, when we go to cost benefit analysis, this is the gold standard in economic evaluation. We can, compare any intervention to another intervention. It's easy to interpret. If the benefit exceeds the cost, then we know unequivocally that we should adopt this intervention. However, in healthcare, they are not widely used. They are used more, they're more commonly used in other fields such as environmental health, and they're recommended for policy analysis. One limitation of economic analyses or an economic evaluation is they're not equipped to tell you how to distribute funds across different groups. And right now, health equity is such a big issue. So economic evaluation will help you determine how to maximize the size of the pie. How do I get the most health out of a given level of spending? But it's not going to tell you how to distribute the pieces of that pie, how to allocate that across different sectors of society. So as I said previously, it's probably not very helpful, but solely alone for looking at health equity issues. So next slide. Thank you for spending the last 45 minutes with us. Here are Tom's and my emails. If you have any questions, you know where to contact us. So thank you very much.
Thank you, Dr. Giff and Griffin, for a very great overview of economic evaluation and cost benefit of analysis, as well as cost effectiveness analysis. Now we're ready for the question and answer period. We have about 9 minutes, and if anyone is interested in asking a question, you can either put it in the chat box, or I believe that we can have you to unmute and you can ask either presenter directly the question that you have. Mabel, do we have any questions that were done previously to the presentation being over?
It's showing no questions yet.
Okay. So if anyone is interested in asking a question right now, you can unmute yourself by pressing *6. And before we close out, I want to give an opportunity for either Dr. Griffin or Dr. Giff to provide any other closing comments.
This is Susan Griffin. I would just like to express my deep, deep gratitude to Dr. Tom Giff for participating in this webinar. Tom is a very distinguished health economist who's with much recognition, and he's been very generous to provide his time for this presentation. So thank you, Tom.
And thank you, Susan, and everyone in the Division of Oral Health for inviting me today. This was a fun presentation. I hope it was interesting for everyone. There's a lot that economic analyses of healthcare interventions can do.
Yes, thank you both again on behalf of the Division of Oral Health for presenting today. And the slides for this presentation, as well as the audio, will be available shortly. We'll send out an email when that occurs. And I just want to make sure before we close out that our next webinar will focus on the CDC Oral Health Surveillance Report. Dr. May Lin from the Division of Oral Health, who's an epidemiologist on the Surveillance Investigation and Research team, will be our presenter. And she was also the first author on this report that came out, and it reflects between two time periods, 1999 to 2004 and 2011 to 2016. And if there aren't any other questions at all, once again, please feel free to reach out to me, or I believe in the slides, Dr. Giff and Dr. Griffin provided their email address, and we look forward for everyone to participate at the next webinar, and we'll be sending out information prior to that. Thanks so much and have a good day.